600 per 100,000. It's enormous. It's almost of epidemic proportions.
This is far greater than I perceive. Traumatic brain injuries, TBIs. When it comes to this figure, the 15 to 20% of military and athlete members have had at least one traumatic brain injury, that really sticks in my mind. And to think it happened at least once, that changes the landscape. Every single athlete on a sports field has more than likely suffered a traumatic brain injury at one point.
For sure. If you do the conventional neuroimaging, CT scan, MRI, almost 100% of the time they're normal.
Okay, so you're not seeing the effects.
And this is the nature of the invisible.
I'm Ashan Correa, and I'm the host of the Strong Link podcast. My experience spans aerospace, defense, and academia, environments built on performance under pressure. And my work now focuses on developing and enabling strong links, the critical enablers who keep teams and missions moving when it matters most. This podcast has one mission: to focus on those high performers who move the mission forward. One dimension of strength we rarely talk about is the mental one, the unseen layer of cognitive resilience, which often goes unheard and unmeasured. It's this invisible burden, the toll on our focus, our decision-making, and our emotional endurance that has inspired this conversation. In this episode, we uncover the unseen costs of high performance with Dr. Alain Ptito, a neuropsychologist at McGill University and the Neuro, the Montreal Neurological Institute. For decades, Dr. Ptito has studied how concussions, microtrauma, and cognitive overload affect the brain's ability to lead, decide, and recover. His research using fMRI, DTI, and neurostimulation reveals what most teams miss: that invisible injuries can have visible consequences for leadership and performance. We'll discuss the neuroscience of hidden brain injuries and why high performers often miss the warning signs, how invisible trauma can silently degrade decision-making, emotional control, and trust, how modern tools are revealing these injuries before they become career-ending, and some practical steps to rebuild cognitive resilience and regain your edge under pressure. Before we continue and dive in, take a minute to like and subscribe if you'd like to hear from more subject matter experts and those with the earned wisdom that enable us to be those high performers, those strong links. Many high-stakes professionals pride themselves on being tough. But what if the brain, not the body, is the first to break? Dr. Alain Ptito, it's a pleasure to have you join us on the Strong Link podcast. I'm very much looking forward to what I think is going to be a really interesting and engaging talk. So certainly welcome.
Thank you. Thank you for the invitation. It's
Absolutely.
a pleasure to be here.
It's amazing to have you here. I'd really like to start with, I've already shared an introduction for yourself and how you've studied concussions, microtraumas, and cognitive overload and how it affects the brain's ability to lead, decide, and recover. I'd really like to start with how common are invisible brain injuries, and especially around high performers, so military athletes, senior executives, and why do so many go undetected or unmeasured?
Well, to answer your first question, about 15 to 25% of athletes and military personnel have had at least one traumatic brain injury in their lives.
Right.
And that may have gone unreported because of several reasons, among others, out of pride, stigma, things of that nature. Although now it's improved, there's much more recognition of traumatic brain injury and its consequences through the media, through people like you that are raising these questions.
Right.
So it's quite common. If you think about traumatic brain injury, you can give a number like 600 per 100,000 in the population. Now, this might seem to be a small number, but if you compare to well-known neurological diseases like Parkinson's disease, we're talking about 20 per 100,000 in the population.
Right.
MS, 3 per 100,000 in the population. So when we're saying 600 per 100,000, it's enormous. It's almost of epidemic proportions.
This is far greater than I perceived it. There's this preconception. Traumatic brain injuries, TBIs, are very rare or are limited to the 1% to 2%, if that, of a specific population. But you're saying...
No, they're not.
Yeah.
They're not rare. On the contrary, I would think they're common.
Right.
The problem is everything that surrounds the idea of a traumatic brain injury. Even when we call it a mild traumatic brain injury,
Right.
it's a misnomer because it implies that the effect will go away for everyone, which is not the case.
Right. And so when it comes to this figure, the 15 to 20% of
Yeah.
military and athlete members that have had at least one traumatic brain injury, that really sticks in my mind. I mean, I did 18 years, and to think it happened at least once, that changes the landscape. I'm thinking of the troops I led or the fellow leaders, and to think even a single athlete, every single athlete on a sports field has more than likely suffered a traumatic brain injury at one point
For sure.
in that
for sure.
career.
And what I should mention also is that if you do the conventional neuroimaging on these people, which is CT scan, MRI,
Right.
the regular MRI, almost 100% of the time they're normal.
Okay, so you're not seeing the effects.
So we're not seeing a structural change.
Okay.
Not because it's not there.
Right.
And this is the nature of the invisible. It's just that the machines are not sensitive enough to pick up any morphological change.
So what would some of the early symptoms be that might indicate you've experienced a traumatic brain injury?
Attention problems. From a psychological point of view, you can talk about irritability,
Okay.
depression,
Right.
anxiety. From a cognitive standpoint, attention problems, memory problems, concentration problems. So these are really things that stand out
Right.
in this population.
And when we think of the triggers, now, especially from my end, I'm new to even learning about the terms of traumatic brain injuries and so on, but I immediately have this preconception it's triggered by one key event, like a concussion, for example. But I was interested to learn more about the connection with micro traumas and cognitive overload that might persist over time that still results in a TBI.
So if we're talking about, let's say, first responders or a high functioning,
Right.
let's say CEOs that have a
Absolutely.
lot of pressure. In the case of first responders, you can have what we call subconcussive blows.
Okay.
And these have a cumulative effect.
Oh, okay.
So if several blows occur in a relatively short time, because before the previous ones have subsided,
Right.
then we're talking about a cumulative effect. And then all of a sudden, the person may undergo just a small tap.
Right.
And the symptoms may just blow up
And it just triggers.
and appear.
We've heard, even from colleagues of mine who have experienced and been diagnosed with some sort of concussion, for example, they use this term that they're living with a fog of some sort. Could you elaborate on
So
what that means?
this fog is common because it combines psychological and neuropsychological aspects.
Okay.
So there is irritability and a lack of judgment that instilled a problem with executive functioning
Okay.
that happens.
And if you could take a moment and really define executive functioning for those
Executive functioning is what is involved in judgment, in planning, in organizing, things of that nature. And it's a very important function because this is what allows us to function better
Right.
by organizing and planning and,
Right.
and things of that nature.
And at its core, so you talked about even micro incidents that can occur and build up over time. Are we talking about a physical shock to the brain that causes the brain to physically move inside the cranium?
It may be. It may also be excessive stress
Okay, excessive stress.
that will mimic symptoms, post-concussive symptoms.
Right.
Like you can imagine somebody that is undergoing heavy stress will have trouble with concentration, will have trouble with attention, may feel down, and may have trouble with executive functioning. Organization may be affected. So is it high stress is definitely dangerous.
This is really eye-opening to me. So is this too much of a leap? Chronic stress or chronic states in a high-stress environment can lead to a traumatic brain injury. Is this brain damage? Is this what we're talking, or is that too much of a leap?
Well, I was separating stress versus a physical intervention by something.
Exactly. Just the stress piece.
So just the stress piece will be a psychological consequence without a mechanical force.
And that psychological consequence.
And that psychological can affect and mimic symptoms. They won't mimic. They will cause this trouble. Okay. So if somebody that is highly stressed undergoes cognitive testing, they will show all kinds of difficulties.
Wow. And those fall under TBIs, traumatic brain injuries?
They wouldn't fall under TBI. They would fall under high stress, etc. That may affect the brain physically.
Function. And this is the executive function.
Yeah, so then you may see alterations in brain connectivity, for instance.
Okay.
So structures in the brain their connectivity will be altered, and that way you'll see some kind of dysfunction.
I'm listening to you. I'm just thinking back to the time, even when I was in the military. Obviously, there's chronic stress and persistent stress states. But even in aerospace manufacturing, during that time, I remember senior leaders, directors, really under some high levels of stress for significant periods of time. And it was ironic because even in my time in the military, I expected to see more injuries and cases of mental health there, for example. But I was surprised to see in aerospace members walking around with full heart rate monitors because of their stress issues. And now to think that there's a link to executive function and brain health.
It's not surprising when you think of it because of blood flow.
Right.
So if you alter blood flow, even in the body, it will alter cerebral blood flow as well. And if you alter cerebral blood flow, you're going to alter somehow function.
Okay. And in our earlier discussion, you mentioned this connection between brain health, measurements on the brain, and blood flow, and how that might now be a different indicator for this type of injury. If you can elaborate on that.
Our research, when we initially started the research, it was, how is it that a certain number of people that have a traumatic brain injury, even mild, how is it that their symptoms, that they don't recover from their symptoms? So about 80% of people that have a mild traumatic brain injury recover within 3 months.
Okay.
But there are 20% out of that 600, that's a lot of people.
Right.
That
don't recover.
That don't.
Okay.
So they have persisting symptoms. And those are the ones we were interested in.
Okay.
Because when we tested them with regular MRI, a conventional MRI or CT, completely normal.
Nothing seen.
And yet they were complaining of all kinds of symptoms. So that's the way we entered the research with functional MRI, which is looking at the brain in activity while the person is undergoing a test in the machine.
So this is where they're in the machine and you're doing some sort of cognitive stimulus to trigger.
We really thought about this. So I was at the Montreal Neurological Institute, which we call the Neuro now.
Right.
And I was working with a colleague, Michael Petrides. And he, at the time of the Neuro and the Penfield era, and it went on that way, they were doing very well-defined lesions in particular areas of the frontal lobe.
Sure.
And that was for the treatment of epilepsy. But at the same time, these patients participated in research. Okay. So Michael developed this test that was sensitive to functioning of that area of the brain.
Okay.
That's the dorsolateral prefrontal cortex. It so happens that that region is particularly sensitive to head trauma.
Okay.
Okay, so it's around here,
Right.
and it's particularly sensitive to head trauma. And there is another region, the hippocampal region, which is particularly sensitive to spatial navigation. So we
Okay.
had two tasks that were tapping into very specific regions
right.
that are known to be sensitive to functioning and to sensitive to traumatic brain injury.
So what were you seeing that was different in a conventional MRI versus a functional MRI?
It's looking at blood flow, whereas
Okay.
the other one is looking at structure.
So you can see, I'm assuming things like flow rate or where you get
So
some resistance.
the rationale is if you're doing an fMRI, the region that is most solicited by the task that you're having the subject do will demand more blood.
Of course. Okay.
So
this is
the
the
blood
connection.
will be increased in that region.
Right. Okay. Okay.
So we were able to test about 200 athletes, I would think,
Wow, okay.
from the McGill varsity teams. So we had a good data bank for comparison purposes.
Okay.
So not only were we able to compare each athlete that was concussed to a group
Right.
of athletes,
Sure.
but we were able to follow them if they had a concussion.
Okay.
Then, so we had a baseline.
Right.
We were able to test them right away after the concussion.
Okay.
And then follow them up 3 months later and see whether they recovered or not,
Okay.
and whether the patterns changed or not.
Right. And if you could build this image for me. So you've found someone who has had a concussion, might have symptoms of a traumatic brain injury or lacking executive functioning. Now you're doing the functional MRI tests. What is it you're seeing that indicates this member has some type of TBI? What's that indication?
So the person is doing the task. We look at the activation patterns.
Right.
We take those activation patterns and we compare them to that 1 to 100 group.
Example, right, absolutely.
And then we see that this person, the activity that they're showing
Right.
is definitely hypoactive.
Oh, I see,
There's
I see.
less activation there.
Okay.
So this is interesting and tells us that, well, maybe if we test a subject and let's say an elite athlete, and they have a concussion, when are they able to return to play?
Right. Okay, interesting.
And so can we contribute to
Right.
this?
Okay. What's the most misunderstood part when it comes to concussions or even mild TBI? What would you say?
The most difficult part is when the patients are they're not they don't believe them. They think
Okay.
they're lying. So essentially, especially in litigation, in litigation, there is a definite problem because the MRI, the conventional MRI, conventional CT scan, they're normal.
Right.
So most of the time, the insurance companies will say, but it's normal, so therefore you probably didn't have a concussion, and whatever you're showing
Right.
is maybe a psychological reaction to having had an accident or a hit or something,
Right.
but your brain is okay.
Wow. And that's
But
going
it's
to
not
prevent recovery. That's going to
Well,
prevent.
it may be true, but we need to demonstrate
Right.
that it's true
Right.
or that it's not.
Right. And you're looking at a few initiatives, if I remember right, to roll out more of the functional MRI testing en masse. Is that right?
The problem that we've encountered is the cost.
Oh, okay. Okay.
If it wasn't for the cost, I think it would become a clinical tool, and that has been my goal,
Right.
is to turn it into a clinical tool because we have enough data now to be able to say there is an alteration of activation patterns. The activation patterns are atypical.
Right.
They're not what we usually see in normal individuals. So there must be something going on there.
Right. And so for those members who are feeling the symptoms, so lacking executive function, they look back, they might have had some sort of trigger for a TBI, and they're suspecting I might have this, but no test result is showing this. What advice would you have to them at that point?
I would suggest that first of all, that they make a list of their symptoms, what they've noticed,
Okay.
and then consult with a neuropsychologist.
Neuropsychologist, okay.
And the neuropsychologist will do the cognitive assessment,
Right.
which can take up to 6-7 hours
Oh, okay.
to do.
Okay.
Because you want to test a whole range of cognitive functions like attention, memory, concentration,
Right.
Intellectual functions, all these
Okay.
things, you know.
This 6 to 7 hour test, I'm just curious. Can it also be used to look at other types of cognitive decline?
Yes, absolutely.
Okay, this is really interesting.
Yeah, so yeah,
Okay.
for sure.
That's really interesting. I know in my family experience and other members I've talked to, for example, they have relatives living with Alzheimer's or dementia. So this is a test you're saying could be applied.
So there are screening tests like
Right,
the
of course.
MoCA or the mental, the mini mental health questionnaire, things like
Right,
that.
right.
That are screening tools.
Okay.
So if a low score happens to, you observe a low score on these screening tools, then you would be justified to push the assessment and identify the weaknesses, the strengths, and see whether there are any signs of some kind of degenerative disease.
Right. Okay. And when we talk about the brain health, traumatic brain injuries, there's also this term which I'd like you to kind of elaborate for the viewers, and that is, what is neuroplasticity and this ability for our brain to adapt and transform? What is that?
So what is happening when the brain is unable to carry out a task, when the specific region is affected, the brain is able to kind of reorganize itself.
Okay.
And solicit other regions to carry out the task.
Okay.
So you may see a performance that is okay, but the areas responsible for that function, for that performance, are not the same ones. So we've seen, for instance, athletes that have had that showed atypical patterns with fMRI. But they were still able to do the task. And we were wondering, but how is that possible? And then when we look at the activation patterns, we saw that there were areas of activations that were different than, so there were additional areas of activation.
So they're functioning, but they're still living with an injury at that point.
So that region is taking over until that person recovers.
Yeah.
When that person recovers, you repeat the fMRI, those additional areas of activation disappear, and you're back to the typical patterns that you see.
Wow, this is really interesting. So even someone who has a concussion that goes through that 3-month period, and let's say they think, okay, I am better, that fog is somewhat lifted, they may still be living with this injury, and it won't show up on a regular.
Absolutely. And this is what the scary part is, especially for athletes or soldiers in the military. It's difficult. You have to make sure that they're okay.
Yeah.
And if they report that they're okay, it's not enough.
It's not enough.
Because we've seen that asymptomatic athletes do show continuing atypical activation patterns. So I think we have to rely on those, and this is why I find it so important to be able to turn fMRI into a clinical tool.
Right. If I were to take it one step further, so members who have this adaptation, another part of their brain is taking over this executive function, and they're persisting in that state. They're still in an injured state, but they're functioning. Is there to me, that's an atypical state. It's not supposed to function that way. Is this going to lead to a detrimental state downstream? Something gives, for example.
I think so, because what we're looking at, we're saying we see an atypical pattern, which means that the brain of this person has not recovered completely yet.
Okay.
So this person is vulnerable.
So that was my next question. So it's the state of vulnerability. Can this state aggravate the chances of something like dementia or other cognitive declining
Eventually it may, but it may trigger damage for a young person.
Right.
You know?
Yeah.
So it's really important to establish that the person has completely recovered. And just doing the neuropsychological testing or just looking at the kind of symptoms they have is not enough, because they will report that they're okay.
Right.
But the brain is not okay yet.
Right.
It may be on its way to recovery.
Sure.
And the last thing you want to do is to expose it to more trauma until it's completely recovered, at least.
Absolutely. And you mentioned, I know it's about 15 to 20, 25% of members in sports and the military that had probably experienced at least one TMI or a concussion or some sort of effect, at least in their career. But with the lack of the ability to do functional MRI testing and the lack of en masse to be able to find this condition, it makes me question how much of the population might be functioning but be in an injured state, which makes me raise the question, how much of our population is vulnerable to cognitive declining conditions?
Well, I would stick to that statistic and say, well, 20% of people that have a mild traumatic brain injury have persisting symptoms.
Right.
So you have to really watch out for those people, because they're definitely vulnerable to a second, because the threshold changes.
Right.
So even a small hit in somebody that is still symptomatic can be devastating.
Right. And so if I just want to bring it right back to neuroplasticity. So for someone who doesn't know that term, so you talked about another part of the brain taking over that function.
Yeah.
Can it also be a source of, I don't want to say recovery, but for example, members with portions of their brain that are significantly damaged? And does neuroplasticity allow us to be able to regain functioning as a form of recovery as well?
So you would use cognitive remediation, for instance.
Right.
Artificial intelligence can really be helpful in designing cognitive exercises that will improve the functioning of such and such a person.
So maybe you're experiencing some sort of executive functioning decline, but there might be some other measures you can take to retrain other parts of your brain to make up.
Yeah, or even that part that is not functioning, or that is functioning atypically, can be stimulated.
Okay.
So the stimulation part, I don't know if you want me to get into that, but
please.
We've used two ways to stimulate the brain.
Okay.
One way was to stimulate the tongue.
The tongue.
The tongue, because the tongue has a direct entry into the brain.
Of course, right.
So there was a tongue electrodes placed on. There were about 256 electrodes placed on the tongue. It's like a tongue depressor,
sure.
But except it has electrodes that allows to stimulate.
Okay.
And at the same time, the person is doing physio.
Okay.
And we've noticed an improvement in balance in those people. Balance is a big problem in traumatic brain injury in a good number of people. Okay. So we've used the tongue as an entry to the brain.
And you're providing some sort of stimulus here to retrain the brain for that.
Walk, and at the same time as the person is being stimulated.
Right.
We had some success, but not as much as we would have liked.
Right. Okay.
So we then use transcranial magnetic stimulation. So this is a magnetic field that is non-invasive, applied to the dorsolateral prefrontal cortex here on the outside.
Right, the vulnerable section, you said, right? Yeah.
And stimulate it, and in those that report symptoms, right? So the areas where we saw hypoactivation, we targeted them with stimulation.
Okay.
And then what we saw, it was an improvement in the symptoms.
And when the symptoms were improving in that particular case, was it another part of the brain compensating, or was it
probably not? I think we're helping that area recuperate.
Wow. Okay.
Well, of course, this is speculative, but
course.
I think we're gearing towards that because we do see changes with fMRI, right? So we
Right.
stimulate, and then we repeat the fMRI after the treatment sessions,
Okay.
and we see changes there.
I feel like it's good to know that there are these approaches, either to stimulate other parts of the brain to take up the lacking executive function, or to maybe set the conditions for the damaged portions to heal.
Right.
I still feel like it comes back to we have to identify that there's a problem to then trigger these recovery or retraining mechanisms. And like you said, the vast majority of members don't have access to the ability to demonstrate that piece.
Yeah.
And it seems like a significant barrier.
The access to the tools, there was a barrier, unfortunately, because we do have some really good tools, you know?
So anyone who's interested, physicians, other researchers that want to avail themselves of these tools, or even just other members, I'm thinking of colleagues I know that have had significant exposure to concussions, explosions, even aerospace and so
Yes.
on. They want to learn more about what they can do to find out and discover that piece. What would you say?
I would put them in the scanner.
Okay, the functional MRI.
A functional MRI.
Right,
I would do that, and
Yeah.
you would see definitely whether there. If you see a normal pattern like you've
Right.
seen, it would be extraordinary because it would reassure that person that, well, you're showing symptoms, but your brain is looking pretty good. So keep on taking it easy until you
Sure.
you recover.
I'm even just thinking about members with family history of some other cognitive degenerative disease, let's say like a condition like Alzheimer's or dementia, for example. But they spent the last 30 years in the military being exposed to explosions or the concussive effects. But let's say they would like to get tested. They'd like to place themselves into a functional MRI. How I know there's a cost to it, but how accessible is it for them to be able to take that step and find out?
So a few years ago, we submitted a grant for a grant,
Right.
and the title was "Making the Invisible Visible."
Perfect.
Okay.
Absolutely,
So this is because of and your title was different, but
Similar.
This is the answer.
Right.
Is and so that's how we got into trying to get an MRI machine that is quite advanced.
Okay.
So we now have one at the Montreal General Hospital.
Okay.
That is dedicated for head injury.
Okay.
And we also have one at the Neuro.
Okay.
So we have two. Where we can carry out testing.
Okay, sounds good.
So yes,
They can reach
it's
out.
possible to do it. At the moment, it's on a research basis.
Sure.
But definitely, I've used it for clinical purposes.
Okay. So there is access.
With a caveat in the sense we say, well, it's still considered a research tool because there hasn't been any jurisprudence at the moment from cases that will accept it as a clinical tool.
Right.
So if we go to court and we present results and say
Right.
this person has damage, we'd say, well, it's a research tool.
Right.
It's not yet a clinical
Makes
tool.
sense.
But it's on its way.
Okay, well, it's good
It's on its way.
to hear that.
It's certainly one of my goals.
I think it's that was my first question. Accessibility,
Yeah.
right? So I think it's a very admirable goal.
So
to
when
work
this happens, I try as much as possible to have access to the machine, which we do. Have access.
Okay, that's good to know. I'd like to take a moment to really talk about this condition of chronic cognitive load and how this can mimic the effect of a mild brain injury. What does that look like? I'm thinking to anyone who's really living that chronic stressed state, that cognitive load state. I know so many members that, and we translate this to burnout, but how does that chronic cognitive load state look like a mild brain injury?
So, again, are you talking about somebody that has had a head injury and that is overloaded with cognitive functioning, or is it somebody that hasn't had a documented
That's the
TBI,
condition.
and is submitted to a lot of stress in their work.
The second case.
So I think, if you think about ADHD, for instance,
Okay.
a lot of it is a lot of people are anxious with ADHD. Now, anxiety and depression will mimic, like you would not believe, the symptoms of ADHD.
Wow. Okay.
So you'll see a slowing of the treatment of information, of processing information. You'll see attentional difficulties, fluctuations in attention, things like that. Okay. And so it really mimics a brain dysfunction. It is possible that because when there is stress, there is high cortisol levels, that in fact, the brain will be directly affected.
Right. Okay.
Okay. So you may have alterations in connectivity between brain structures because we're having somebody that is stressed out and that is mobilizing several regions of their brains to be able to function better.
Right. Okay. And
so definitely there could be a problem with processing of brain in the brain.
Right. So this physiological condition, let me know if I've got this correctly. So someone who's undertaken that chronic stressed state and has reduced adaptive or cognitive load consistently, this might translate to other parts of the brain trying to compensate because of the declining executive function.
Yeah.
But that's a physiological change.
Yes, it
to the
could
brain.
be, exactly. So from a psychological state,
Right.
you can go into a dysfunctional state, but from brain mechanisms.
Right. Okay. So if someone who's experiencing that and may not know it, if I were to fall back to the TBI approach, is there a way for us to retrain the brain to better manage those stressed states in the typical way versus trying to compensate with other portions of the brain?
The advantage with humans is that we can talk. So somebody can tell you that they're anxious, and
Right.
so you can work on that to reduce the anxiety. And if you reduce the anxiety, you'll probably see from cognitive testing that they're improving.
Right.
So this is the way to do it, is to listen to the patient, to what they have to say.
Okay.
Now, it depends on the kind of patient, because if we're looking at athletes who want to return to play, they'll tell you they're fine.
Same thing with the military.
And the military,
the
same
with
thing,
executives.
they're fine.
Absolutely.
You know, I'm doing great.
I want to know, I'm imagining this relationship. Stress induced on an individual, there's a typical brain function, blood flow going to the right parts of the brain that are translating into proper executive function. This is the ideal state. Stressors are introduced that now cause the members to experience higher levels of stress and anxiety in a chronic state over time. And now we see this atypical compensation starting to take place, blood flow going into other parts of the brain to help the member maintain executive function, but they're now in this atypical state. Now we take out the stimulus. Now we reduce the stress. They talk, they are able to reduce the anxiety, and it goes back to that typical state. This is now talking about resilience. Is there a way for us to train ourselves, improve our brain health, where we can manage higher levels of stress, or at least those stressors, while preventing that atypical state, increasing that resilience? Is that possible?
Well, I would like to be able to answer you.
Of course, this is the golden question. Absolutely.
But it's not obvious. What my hunch is that when you're functioning at a very high stress level, the cortisol in your brain will be very high, and hippocampal areas are particularly sensitive to cortisol.
Okay, right.
So, and they're responsible for memory.
Okay.
So you will see these kinds of memory problems.
Right.
Usually, like memory, for instance, if I read a short story to you and you have to repeat it, things of that nature.
Sure.
In high-stressed individuals, you may see trouble with memory, which will dissipate when the anxiety level
Okay, so
goes
that memory
down.
function starts coming back
Yeah.
once that
Yeah.
gets
So I think
removed.
we're talking about interference with cerebral functioning.
Interesting. Okay. Have you experienced, and can you share a case study or an example where a seemingly fine person is experiencing a brain injury that is later or impairing their performance? Is there an example that comes to mind from the members you've worked with?
So I remember an athlete who had a concussion.
Right.
We tested him with cognitive testing, with fMRI. And we saw on the fMRI, it was okay on everything else. fMRI was not great.
But his executive functioning was, he was
His
good
executive functioning was okay from the testing.
from the testing.
Don't forget, we're testing in quotes, a laboratory setting. So we're in the clinic. We're not in everyday life.
Right, right.
You know, we're not at the person's office.
Absolutely.
And, you know, so but still, they did okay. That person did okay. But the patterns, the fMRI activation patterns were not great, were atypical. So we felt he's not ready to go back.
Okay, okay.
He went back
Okay,
and he got into a fight
okay.
on the ice, and it was a career-ending.
Wow, so this triggered that tip over.
I'm pretty sure.
When you say a career ending, are we talking about a significant drop in executive function? Like there was a significant cognitive decline?
A significant drop in everything.
Oh, wow. Okay. And
So generalized,
sure.
Effect.
Wow. And so how long do you think that person was living with a TBI?
That person had just had the TBI,
Right.
had supposedly recovered because, for all intent and purposes, all the tests were okay,
yeah.
except for one, the fMRI.
That's it.
And that one was quite telling, unfortunately, from the result later on.
Right,
So
right.
there was a vulnerability there, and we interpret it as a vulnerability when we see ongoing atypical patterns.
Right.
So we feel that if we see an atypical pattern, don't go back to risking another trauma.
Right.
You
And
have
that's
to
such a
wait
hard...
and keep on working on recuperating, but don't go back to contact.
Right. And I'm assuming as soon as that got triggered, recovery may not even be an option where you're looking at sustaining that state and somehow regaining function.
So we didn't follow that person.
Sure.
But I imagine that they must have we would still see some kind of atypical pattern.
Yeah.
know?
Okay. That's...
I don't know what it will be like in the future. Will we see something like a cumulative effect of the traumas,
Right.
and then lead to some kind of degenerative disease,
Right.
like chronic traumatic encephalopathy. But we don't know. We don't know for what the future holds for these people. But there is definitely a cumulative effect of concussions.
Absolutely. And this cumulative effect making the large vulnerable population here susceptible to... I see there's two points to be worried about from members that might experience this. One is one more concussive instance, which might be very light, could tip over into that cognitive decline state, but also just being more vulnerable to things like chronic stress and anxiety that might later tip over into a cognitive condition like Alzheimer's or dementia. That's worrisome.
So let me take a small tangent here. Sure. A colleague of mine with whom I started all this was Dr. Karen Johnston, who's a neurosurgeon, approached me in the hallways at the Neuro years back and was wondering about depression and saying that a good number of the patients she was seeing that had a concussion were complaining of depression.
Okay, so that could be one of the big indicators.
We thought Is it because the person is not able to return to play, so they're feeling kind of down? So we pushed it, and we had them do questionnaires, and then put them in the fMRI, and we did a literature search, and we figured out that there was a loop that existed with regular depression.
Okay.
I call it regular.
Sure.
Okay, because we're talking about depression from trauma. And so we saw a pattern. So we were wondering, if it's a true depression, we're going to see the same pattern in concussion.
Okay.
If they're complaining of depression.
Right.
And we saw exactly that. We pushed it further. We said, okay, but is it possible, or are we on the right track?
Right.
It so happened that we had two sets of identical twins, and one in each pair was depressed, clinically depressed, and the other was not. And we looked at their fMRIs. They accepted to participate in the research, and we saw the ones that were depressed showed exactly the same pattern as a clinically depressed individual without trauma, without concussion.
Okay.
And the other pair of the twin, no problem, typical patterns.
So this was someone who was having the symptoms of depression, but didn't have a concussive trigger, for example.
Yes, they did.
Oh, they did.
So what I'm saying is that there are a consequence of one of the consequences of a traumatic brain injury is depression.
Is depression.
And this is something to look out for.
Right.
It's really, really important.
I'm just, I think back to even my time in the military, and for members who were just not even exposed to explosions or those obvious triggers of a concussion, for example, but distinctly remember like our mental health lines, or we had members like Padres who would be 24/7 on a helpline ready to answer for anyone who needed that assistance, and how busy they were. It shocked me to see that. And these were members who were mechanics, engineers, administrators, but may, like to your point, may have experienced a concussion or a TBI at some point, and now we're seeing higher levels of depression.
Yes.
Right. That's really eye-opening.
Yeah, and it's really clear. So now systematically, we have them fill out questionnaires on depression and anxiety.
Right.
As well.
So, speaking as someone who's, according to the statistics, I've more than likely suffered a TBI at some point, or a concussion, and which I can definitely say has probably happened.
You look fine to me.
Which I wish was a good thing. But now I'm concerned. But I'm looking ahead, right? I have family history with members that have also suffered with things like Alzheimer's or dementia. And I'm thinking about my relationship and experience with stress and high anxiety states. And I'm looking ahead and wondering how much of my functional state has been sustained in an atypical way. And I don't have, the triggers. I don't have access to fMRIs or maybe the resources to look into it. But I want to strengthen my brain health, at least mitigate what I can control, right? What would you advise?
I would advise to do a neuropsychological assessment, a full neuropsychological assessment.
Is that the 6 to 7 hour assessment? Or is it separate? Okay.
Yeah.
Okay.
So then you would be able to tease out the strengths and the weaknesses and work on the weaknesses, make out a cognitive remediation kind of program personalized for that person.
Okay.
And then have them work on it.
Okay.
And I think, and that's where the plasticity comes in.
Right.
Okay,
right.
So you push and you push and you push. No longer do we say after a concussion you sit in a dark room and do nothing for hours on end.
Right.
Now you just start and get into it right away.
Okay, it's really interesting to me. I remember early on when I had a family member that succumbed to dementia and Alzheimer's, and I was just doing some research on what is there that helps. And just through that research, I remember a study that looked at they were a group of nuns, actually. And what they found is after they had passed away, they had donated their brains to research, and they had done, actually looked at their brains. And they found a number of them had symptoms of, or the signs of Alzheimer's or dementia at the time, but they were functional. And what they found was these members were consistently doing high cognitive load work, like research. Some of them had multiple PhDs, and this had caused the brain to keep functioning, learn new ways of doing so.
Right.
So that
This
was interesting.
Yeah. So this is the idea.
Okay.
Other regions would be able to a certain extent take over.
Okay. So
and contribute.
Right. So I'm looking back. May have had a TBI. I'm worried that I might be vulnerable to cognitive decline. The assessment you mentioned is what was that called again?
A neuropsychological assessment.
Neuropsychological assessment. That's a good starting point.
It's a good starting point.
Okay.
To test, and it's a good baseline as well.
Right.
Because then you have the data of today,
right.
2025, and then in 2-3 years, in 2025 we did this. Let's repeat it and see.
Right.
Because the person is complaining of all kinds of problems. Can we document this?
Right.
We have the data from 2025. Now we're in 2028. Let's look.
Right.
And compare.
And that neuropsychological assessment will also yield exercises that you can do. Okay.
Yes.
Okay. I think
exactly. So it's multi-purpose. It's really I think it's a good way to.
I think this is amazing. I think anyone that's even in a high stress state or is exposed to any triggers that could be impactful to a vulnerable population should be doing this assessment, right?
I think so.
That's really insightful. I'd like to know, when it comes to, let's talk about leadership and performance, for example, and in your experience, what happens to leadership and trust when someone doubts their own cognition, right? And a lot of members keep this private to themselves, right?
Because if you keep it to yourself, because if you show any kind of weakness, then you lose self-confidence, of course.
Right.
And you lose the respect of your colleagues.
Right, yeah, absolutely.
So that's what happens. And of course, you're not going to function as a leader. This is not the kind of image you want to project.
Right.
Although a team should understand that a human being is by nature vulnerable.
Absolutely. And this was my second question when it comes to being a member of a team and being exposed to members that may be experiencing these invisible declines, right? How can teams respond better to someone that might exhibit some executive functioning decline?
Yeah, so they for instance, I think support is essential.
Okay.
So feeling that the team is supporting me, feeling the way I'm feeling is incredible, because it changes from being judged to being supported. So that's a huge distinction.
And if I were to pull on that a bit more, even that support can reduce the stressors that might return their function from an atypical state to a standard.
And here we come back to anxiety.
Right.
If we reduce the anxiety, we'll be able to function better.
Right.
So I think in leadership, that this is what happens. You need the support from the team. The team has to be aware, and so there's education to be done with the team, not only with the person that has that has the trauma, but also with the team that will give that person support.
Absolutely.
So if they don't know what's going on, they'll say, they'll judge that person. They'll say they're awful, they're irritable, they answer poorly, and all these things.
Making it worse, aggravating the atypical state potentially.
Exactly.
Am I right to think recovery really may only take place in the typical state? Like we may need to remove the stressors to allow the brain to function the way it's supposed to before recovery can take place? Or can the brain recover while we're in this atypical state?
That's what I think is happening.
Okay.
It's happening at the same time.
At the same time. Okay,
yes.
Okay.
And the brain, I think the brain needs to be stimulated.
Okay. For recovery.
For recovery.
So
it needs to be, to function, it has to be stimulated.
Right,
so for recovery, it has to be also stimulated.
Right. So to your point about don't just lock yourself into a room and cut the sensors out.
Don't sit in a dark room doing nothing because it will do nothing.
It'll do nothing. There we go. That's very powerful. And I can think back to those members that tried to do that, and and that fog didn't disappear.
Right.
And actually, I'll ask you this. I've known members who experienced that concussion, that said they went through some of the toughest times of their life in the months that followed. That drop in executive functioning was so depressive, it really caused them to move into a negative state. And then they seem to get better. But then a decade later, they're introduced to some other stressor, something that raises their stress and anxiety. And then all of a sudden, they're doing some type of processing. They're dealing with this problem. And then suddenly they say, something changed. The fog is lifted. I feel like my brain is functioning the way it was supposed to. Have you seen this kind of effect at some point where something seems to fix itself?
To fix itself.
Now, it may not be real. Maybe
it's difficult to imagine that something will fix itself, because probably what happened is that they're still being stimulated.
Right.
Maybe not in a systematic way as we would do it in a clinic or in a lab, but they're still being stimulated because they're awake.
Right.
So
Makes sense.
there are things going on around them, and it may be that at some point, when do the symptoms dissipate completely? Maybe that person has reached that point where everything has dissipated, and now they're feeling good. Right. Maybe it's part of that 80% of people that have a mild traumatic brain injury and that recover within 3 months. So you may see all of a sudden a recuperation.
Right. Okay. And this kind of leans into the second question. We've talked a bit about it, but if I were to ask us to focus it on a specific question, what's new in neurorehabilitation that can give us hope?
So, aside from using the artificial intelligence to stimulate cognition, there is the transcranial magnetic stimulation that gives us a lot of hope, because we didn't want to leave the thing as we're going to do we're going to help with diagnosis with fMRI. And then what? You're going to send the person home and live with their problem? So we need to think about is there an intervention that would be helpful?
Right.
And this is where the stimulation came in. And we tried several different approaches, and we feel that transcranial magnetic stimulation could be helpful.
So for someone who doesn't know, what is transcranial magnetic stimulation?
So it's simply a magnetic field with a coil that you place on the head, and it stimulates the cerebral regions that are under that region.
Interesting.
Simply.
Okay.
So it's not painful, it's not invasive, it's not anything like that. It takes several sessions. Here in Quebec, the government pays for treatment of depression with transcranial magnetic stimulation, and it's really efficient.
Wow. Okay.
So it takes about 25 to 30 sessions of transcranial magnetic stimulation to alleviate depressive symptoms.
Wow. Okay.
And sometimes they need boosters. They call them booster sessions. But it works.
I mean, this is amazing to hear, because members who suffer with depression, anxiety, we think, okay, maybe the only solution is to be medicated, drugs and so on, or some other type of measure. But this is...
It may be that the combination of the drug and the stimulation will be the best combination.
Okay.
We know that the best combination is psychotherapy and medication.
Right.
That works very well. It works better than either one alone.
Right.
So same thing.
Okay.
For transcranial magnetic stimulation.
Really interesting. Transcranial magnetic stimulation. I need to look this up because that sounds really interesting. And if I would...
In fact, sorry, we've been talking about... I've been talking to the veterans.
Yes.
So we have been seeing veterans. I would like to instill doing fMRI with them. you know.
You'll have my full support. I'll tell you that right now.
So,
Absolutely.
you know, we'll see if they decide to fund this kind of work, you know,
Certainly.
but with a clinical perspective. You know, I mean, we've done the research.
Right.
We should be trying the clinical aspect.
Yeah, and you just reminded me. I did have a question because I had engaged some members. This whole initiative is about enabling those strong links, the critical enablers, those high performers who may be in a vulnerable state and are inundated by chronic stress. And I reached out to a few members, and we had one question. This is from a member from our Special Forces community. He was a breacher. So these are the members who are responsible for using explosives to gain entry or establish some type of effect. And there's this convention that when you're using these explosives in a confined area, let's say an urban environment, the concussive effects can be much more pronounced. And there's some best practices like, you know, to not be positioned in the corner of a room because it can amplify the effects. But I remember you were speaking to this relationship between the shock waves, the concussive effects, amplification, and its relationship between close in, but also far apart. For example, with IEDs that we were talking about before. Could you shape a little bit on that as well?
What happens is if with these devices that are explosive devices, the rationale is, if you can imagine a picture of throwing a stone in a pond.
Right.
And then you'll see the
ripples.
The ripples. And so what happens is when somebody is exposed to an explosion that way, the same ripples happen, and they hit the body, and all the blood vessels in the body shake or are affected.
Right.
So blood flow is affected. And then all of a sudden you have an invisible injury.
Wow.
Because you don't see anything. The person wasn't directly exposed. So, and then they're complaining about all kinds of symptoms.
Right. And this can lead to things like depression and other...
And first, they may not, whoever is in command may not believe them.
Right. Yeah.
You see?
Because you were so far away.
Because you're so far away,
Right.
why would you show these symptoms? There's no reason. So you're making this up.
Oh, now I completely agree. I have probably suffered. I can there's a number of explosions that were supposedly outside the minimum safe distance, but I felt that effect.
And so it's difficult to understand and justify. But when you start looking at the mechanics, then it becomes a little bit better to understand.
Absolutely, it's really interesting. I'd like to look at mindset. So what mindset shift do we need to incorporate? You've touched a little bit when it comes to support and so on, but I think of it as a larger approach. We talk about planning and implementing decompression periods, looking at these power stressors that might be present in our environment, making the realization we're more than likely leading teams where there's a significant percentage that are in a vulnerable state right now, whether we know it or not, and we can't see it because they're in a functionally executive state, but there might be some sort of compensation piece that's in play. What's the mindset shift as a high performer or as a leader that we need to incorporate?
I think the first thing we have to accept is that we're vulnerable.
Right.
And as soon as we accept that we have some vulnerability, then it becomes easier to handle whatever happens to us and develop techniques to be able to circumvent that problem. And the same way the team has to realize, we have somebody in place that is great and a leader, but they could be vulnerable.
Right.
And can we support that person? So we should be trained to detect whether it's a leader or something, or there's something wrong. You can see the person may be irritable, maybe answering in a strange way, things that are not typical of that person. So when you see those changes, when those changes are perceived, this is when the shift is happening, and where the person can be helped.
Okay. I like that approach, definitely. And when it comes to...
So then it becomes a team effort, and in the military it's primordial to have this team,
Absolutely.
this feeling of appartenance, of belonging.
Right. Which is a challenge, especially for members who are transitioning out, who lose that support, but might be suffering from a traumatic brain injury. When it comes to neuroplasticity and my ability to do things that can enhance that ability to manage these conditions. For example, I'm thinking about someone who goes to work, is in that stress state, comes back and tries to shut down stimulus as much as they can. Maybe they're just putting on Netflix and letting the mind go that way. Is there an approach that we should do that allows us to really maximize the effects of neuroplasticity to our benefit? Should I be reading more? Should I be constantly learning that triggers these cognitive changes? What were your thoughts?
Three things.
Okay.
Social, cognitive,
Okay.
and physical.
Okay, there we go. Social, cognitive, and physical.
You have to do all three.
Okay, this maximizes neuroplasticity
I think so.
to increase
I
resilience.
think it places you in a good place, in
Okay.
a good spot to be able to
Right.
expand.
So keep socializing, keep those engagements going,
And physical exercise.
right, physical exercise and cognitively challenge yourself.
Cognitively challenge yourself.
Right.
Ideally keep on working, maybe
Right.
less
Sure.
or whatever,
Sure.
new kind of approach, but
Right.
definitely keep on being stimulated
Okay, I really like
intellectually.
that. Social, cognitive, physical. That's amazing. I really like that approach. When it comes to what's one thing that you wish every high performer understood about their brain limits?
The brain that doesn't have much of a limit except for that person.
I love that.
For that person. That person can develop his or her brain to its maximum, and that has no limit except for what you are doing and what you're stimulating with.
Okay.
So-
okay. So don't perceive that there is this limitation.
There's no
There is no.
limitation.
Right.
I
Take
don't
these
see
measures.
I don't see a limitation.
Okay.
Really.
I really like this because there's this preconception that I will have this cognitive decline as I age, as I retire. But there are things, like you said, social, cognitive, physical, maintain these attributes.
Yes, and we see it in the elderly. They function better. I mean, we're seeing, first of all, prolonged lives, and we're telling these people do all this kind of stimulations, and they are feeling better. And now we see more and more the elderly. Sometimes you can't even tell the age of somebody that has an advanced age. You know, it's really interesting because this is a shift. We used to see people that were 80 years old that looked absolutely old.
Oh,
you know, we qualified them. In my time, 80-year-olds were like, okay, that's it.
Sure, yeah.
Now, an 80-year-old can still be a university professor. You know, can function extremely well.
Absolutely. I'm thinking even to I run this Ascend mountaineering program, and I remember my very first alpine course. And it was interesting. There was me and a colleague who was a U.S. Senior NCO. So military backgrounds were there, and there was two members in their mid-70s that were out performing, hiking, all of us. And they were in great shape, physical, mental. And I think back to them, and they were always very physical. They were hiking in the mountains in New Hampshire all the time. They were very social as well, incredibly friendly members. So I think it really comes back to that social cognitive. One of them, I remember, continued to captain a fishing vessel as well in their spare time. Obviously, a high cognitive task load. Yeah. So really, really interesting.
So, so this is, but of course, it's always within the limits of what that person has always done.
Right. Absolutely.
You're not going to ask somebody that never went hiking
Sure.
to go to the Himalayas,
Right, yeah.
because it will stimulate them.
Absolutely. There's other ways you can
Right.
challenge yourself
Right.
in that way. And as we come back to the end of this interview, there's the real question is the start point. Someone who's experiencing lacking executive function, depression, anxiety, and they're looking back and they may have had some instance on a concussion or TBI or not. We talked about it, but where do they start? What's that start point to just? I know you mentioned document your symptoms.
Yeah, but
What's that?
I mean, if you're feeling that you have a problem,
Right.
a cognitive problem, I'm getting older. Do I have a problem or not? I would suggest that it's a good investment to do a neuropsychological assessment.
I definitely agree.
So, and then tease out your strengths, weaknesses. If you have a normal cognitive profile, imagine how happy you'll be.
Right, absolutely. That's a really
so you'll
good
be
point.
reassured. You'll be and then you'll be told, well, you try to work on this and this and that, and you should be really fine.
Right.
Whereas, well, your pattern is looking abnormal. So you go to you see a neurologist, and then we're going to work with the neurologist and see, confirm with other tests.
Right.
With the kind of problem that you have.
Right.
But the person, should not be feeling like they're dreaming their problems.
Right, absolutely.
Because
Quantify
then
it.
you can fantasize over this, and it'll become a vicious circle
Absolutely.
and a preoccupation for
Right.
a long time.
Further aggravating the stress. Yeah.
Yes.
We've covered a lot on this topic. This has been incredibly insightful. But Dr. Alain Ptito, this is an absolute pleasure. Thank you so much for taking the time. I can't wait for more engagements with you and just to pull more of your vast knowledge. It's incredibly enabling.
It will be a pleasure, and thank you again for the invitation.
Fantastic. Thank you.